Many reports have demonstrated the operative safety and oncological efficacy of VATS lobectomy. However, large reports, including those from our own institution, have focused on the number of VATS lobectomies performed successfully, but not on intraoperative complications. Therefore, we reviewed our experience with catastrophic intraoperative complications. The primary objective of this study was to quantify the incidence and to provide specific details of catastrophic intraoperative complications during VATS lobectomy. The MSK thoracic database was explored after IRB approval. 9 surgeons now perform VATS lobectomy, and our technique has been described previously. All patients who underwent VATS lobectomy or a combination of any thoracoscopic procedure and a thoracotomy were identified. A catastrophic complication was defined as an event which resulted in an additional unplanned surgical procedure other than the planned lobectomy. From 2002 to 2010, 633 VATS lobectomies were performed, and 610 patients had any VATS procedure followed by a thoracotomy. 13 catastrophic complications were identified in 12 patients. Surgeons' experience, learning curve were not predictive of a catastrophic intraoperative complication. There were no intraoperative or postoperative deaths. We classified complications into 5 different categories: injuries that occurred while working on the pulmonary vein, pulmonary artery, bronchus, injuries to intra-abdominal contents, and injuries from the mediastinal nodal dissection. We'll start with the venous injuries. Patient 1 underwent an attempted left upper lobe VATS lobectomy. The entire venous trunk, both superior and inferior veins, were transected. Thoracotomy was performed, the left upper lobectomy was completed. The staple line of the transected vessel was excised, and a primary venous anastomosis was performed, sparing the lower lobe. Patient 2 underwent an attempted right lower lobectomy. Patient first underwent the usual division of the right lower lobe vein. Then, upon dissection of the right lower lobe bronchus, the staple line of the vein opened and retracted into the pericardium. Expeditious thoracotomy and primary repair was performed. Upon closer inspection, it was noted that the initial staple line had incorporated pericardium into it, which led to the staple line disruption. Patient number 3 underwent an attempted right upper lobectomy. There was a significant amount of calcified lymph nodes on the artery. The vein and truncus arteriosus were divided. Then dissection of the posterior ascending pulmonary artery resulted in a large tear that required thoracotomy, intrapericardial control. The artery had been injured beyond repair, and a pneumonectomy was performed. Patient 4 attempted left upper lobectomy. Initial dissection of the pulmonary artery of the first branch resulted in a large tear in the pulmonary artery. Thoracotomy was performed. This was repaired primarily, and the left upper lobectomy was completed. Patient was discharged home on post-op day number 7, only to return as a transfer from another hospital 4 days later, intubated, septic, with opacification of the remainder of the left lung. CT demonstrated a thrombosed pulmonary artery. A completion pneumonectomy was then performed, and pathology demonstrated necrotic lung. Patient 5 underwent an attempted right upper lobectomy. The right main pulmonary artery was mistaken for the truncus branch and transected completely. Thoracotomy was performed, the right upper lobectomy completed, and a primary anastomosis was performed, salvaging the remainder of the lung. Patient 6, right upper lobectomy. Upon transection of the right upper lobe vein, it was apparent that the ongoing pulmonary artery had been encircled as well and transected simultaneously with the vein, distal to the truncus arteriosus. Thoracotomy was performed, the right upper lobectomy completed, and a primary arterial anastomosis was performed. Patient 7, left upper lobectomy. The main PA was mistaken for the first branch of the pulmonary artery and transected, and the main stem bronchus was mistaken for the left upper lobe bronchus and transected as well. Thoracotomy was performed, and upon closer inspection, it was deemed that the patient required a pneumonectomy for oncological reasons. Patient 8 had a completed VATS right lower lobectomy. There was a very thick anterior portion of the major fissure. At the end of the case, the right middle lobe did not inflate. It was apparent that the right middle lobe bronchus had been transected with the anterior fissure. Thoracotomy and bilobectomy, including the right middle lobe, was performed. Patient 9 also had a completed right upper lobectomy. At the end of the case, there was a huge air leak. A large tear was identified going from the bronchus intermedius to the right main stem bronchus in the membranous portion. This was repaired primarily. Patient number 10. This is not a lobectomy. This patient underwent a routine VATS left upper lobe wedge for actually benign disease. Post-operatively, the patient was hypotensive with a dropping hematocrit. CT scan documented an injured spleen. The patient underwent a laparotomy and splenectomy. Of note, there was no diaphragmatic injury at this case. Patient number 11 underwent a successful right upper lobectomy. Then during the level 4 mediastinal nodal dissection, a large portion of the superior vena cava and azygous junction was torn. Thoracotomy was performed with primary repair. And patient number 12 underwent a successful VATS right middle lobectomy in a level 7 mediastinal nodal dissection and was discharged home. 2 weeks later, the patient presented with the left bronchoesophageal fistula. Primary repair with the muscle interposition was performed. Then 6 weeks later, the patient presented again with the right bronchoesophageal fistula, underwent primary repair with muscle interposition. 2.5 months later, persistent empyema of the right chest, underwent an LOS or flap. This is a summary of all the cases, age range 46 to 80, an equal distribution of men and women. The majority were upper lobes and early stage disease. Median length of stay was 7 days, and all are alive to date. In conclusion, catastrophic intraoperative complications of VATS lobectomy are uncommon. However, awareness of the possibility of such injuries is critical to avoid them. Development of specific management strategies and lung-sparing techniques are necessary to limit morbidity should they occur. This is the team who made all these complications possible. This is actually a very great team, and if this could happen to this team, it can happen to anyone in this room. Our VATS studies would not be possible without the leadership of Valerie Rouche, my partner in crime, Bernie Park, and the legendary Manjit Baines. I have recently moved, and this is my new home at Mount Sinai. We have a great team. Cindy Chin is in charge of our VATS program, Andrew Kaufman, the head of the Translational Research Lab, and Todd Weiser from the NGH in charge of our airway program. Thank you.
The discussion will be opened by Dan Miller.
Dan Miller, Atlanta, Georgia. Wow.
How do you think we felt?
No. Congratulate you on this talk. Congratulate you on your honesty of bringing this to the forefront. It's kind of interesting, there was 12 patients that were injured here. This was the same number of patients that had major complications in Dr. Park's robotic series. Were any of these robotic?
No.
Okay, good answer.
That's right.
The thing that concerns me, my first question is a lot of this is anatomical issues, especially in regards to the pulmonary artery and pulmonary veins. Total transection of the pulmonary artery in the bronchus, that's like a Ralph Lewis procedure. But the big thing is what have you learned from this, and what can you tell the audience? Because when you do bronchial stapling, you can do a ventilation test, even though you had one issue with the middle lobe vein. But what can you do to prevent this occurring again from a pulmonary artery, and especially the pulmonary veins? As you know, 15 to 20% of the time there's a common vein on the left side. What can you tell us of how to prevent this?
I think there are many things that I've learned from reviewing this series. Number one, the thing that I've learned is that it's very difficult to identify these patients. From large databases, frequently the query is looking for lobectomies, and that will miss the pneumonectomies that are performed as a result. So I think these complications are actually underreported in the literature. With every structure, I have learned a huge deal when it comes to VATS lobectomy. With the vein, if there's any doubt, take down the inferior pulmonary ligament, identify that inferior pulmonary vein, identify the superior pulmonary vein. Any doubt, you have to go ahead and take down that ligament. It takes a little more time, but that's what you need to do. When it comes to the pulmonary artery, 2 rules of thumb that I use. Number 1, identify artery that's continuing. So when you see a branch, don't just take it, make sure you see more artery going down to the rest of the lung. Avoid the crotch. A lot of the bleeding comes from going into that crotch. When you see the crotch, you go a little bit higher. That will protect you from the big bleeding. With the bronchus, like you said, most of us do this openly, where we go ahead and we inflate the lungs prior to transection. I think another key is if there's any doubt about a middle lobe bronchus being hidden in the fissure, maybe during that situation you want to inflate as well and identify that you could have possibly included that in the fissure. When it comes to the intra-abdominal injuries, I think that this particular case, the VATS was performed in the usual way that most of us would perform it. There was no diaphragmatic injury. What happened was the fellow continued to take the stapler and push it into the chest, met some resistance at the skin, and kept hitting the diaphragm and hitting the spleen underneath. And that's what led to an injury. So I think when you have someone inexperienced on the other side, make sure that you watch them directly and that stapler is going up and not hitting the diaphragm. You don't.
Just try to be brief, so we got a lot of people want to discuss your paper.
Okay.
Yeah, the second question is in regards to the lymph node.
I could talk about it all day.
Don't do the meso thing.
If we have...
The next is in regards to the lymph node dissection. 2 of the injuries, one to the bronchus, one to the vena cava, was probably related to the technique of removing that, because sometimes you can ring forceps, pick up, and cauterize. We've switched to an energy device. We use NSIL, you can use ligature, any bipolar. That cuts down on that inadvertent injury to those associated vessels. Once you could comment on that.
Yeah, I think, any kind of new technology warrants practical use, and I think that, I know yourself and Dr. Swanson both are big on the energy devices, and so I think I don't use it. I use cautery and I use the argon beam, but I think it's important to go ahead and look into that. There was an injury with the left upper lobectomy that I think was as a result of the argon beam, and then upon blunt dissection, the artery opened up. So I think you have to be very careful about vascular injuries, and maybe the energy will come into play with that.
All right, Dr. Patterson?
Just one more.
Okay, sure.
And the last thing is in regards to quality assurance. It's very important after these events occur that you have a debriefing with your team in the OR, because the nurses, they feel terrible. And this is what we're all going through our checklist now and so forth. It's very important to get the team involved in that and how you can prevent it in the future. If you don't do that, it will come back to bite you.
I think that's a huge point, and we're going to start doing that at our institution.
Alex?
Yeah, Roger, you should, Alec Patterson from St. Louis, you should be congratulated. You got a lot of courage and a lot of honesty. This just reinforces my conviction. This is for everybody in the room. If you want to get an abstract accepted at the AATS, all you have to do is put the word complication in the title, and it's definitely on the program. I was also going to say it's a good thing there's only 12 cases, because you never would have got through it otherwise. So I noticed, and just for clarification, it seems to me another big problem are injuries that occur to various structures that result in a thoracotomy but don't change the ultimate operation. A hole in the PA, hole in the vein or something like that. You have to make a big operation out of it, but the patient still just gets a lobectomy. Those patients were not included in there. Even patients who had a major amount of blood loss.
We tried to focus in on patients who required some other separate procedure. Now, I included a couple things like the SVC injury just because I thought they were good learning points, but in the patient who had a PA injury where we just took a few proline sutures to oversew it, even if the patient required a unit of blood, we did not include that.
Okay.
That is actually included in our initial paper from 2009, which looked at the complications, and there were 11 of those.
Dr. Waddell?
Yeah, I'm interested just to get into the exploration of why the injuries happen. I think you did a pretty good job of that, but if I understood it correctly, it was just from reading the operative notes. You didn't have the opportunity to review videos, and you didn't have the opportunity to interview the surgeons involved, so...
No, I actually did interview the surgeons. So we identified the patients from looking at the operative notes. Once we had the operative note, I contacted each individual surgeon and discussed the case with them to get specifics.
Right. I think it would be very interesting in this kind of analysis to try to break it down in terms of cognitive and technical misadventure, or whatever the word is, but I really applaud you for doing it. Very, very helpful.
Scott?
Swanson, Boston. Very nice, Raja. I think you should be a little more circumspect, because many injuries occur during thoracotomies that are due to lack of understanding of anatomy, misidentifying anatomy, which were at least half of your complications were related to misidentifying anatomy. And so I find it hard to believe it's not related to experience. When I first began doing VATS, there was a lot of issues around identifying what you were doing. So I bet if you really could analyze it, experience plays a huge role, because you're already saying you know tips to look for veins and look at the arteries, so that's experience. So I'd say, one of the issues is this isn't just VATS, it's surgery, and two, I do believe it's related to experience.
And I think that was one of the main points of this paper, is that experience, no matter how experienced you were, it can still happen. So you have to be very vigilant. I do agree with you. I think that with experience, you get a much decreased rate of your conversions, but even if you're the most experienced VATS surgeons, this can still happen.
Thomas?
Tomasz Grodzki, Szczecin, Poland. Raja, it was fantastic paper. I have just two short questions. Were those complications connected with somehow with a learning curve, or did they happen during maturity? This is the first question. And the second was, I appreciate both two teams and legendary Sloan Kettering team, and the question is a little bit discreet. Was the distribution of those complications rather equal, or there were some leaders?
They're all Raj's complications.
Yeah, no, the complications were not by any one specific surgeon. Each surgeon had at least one or two. And I think it's important that we learn from from these experiences, so that it doesn't happen when we do it. I mean, I've learned from just putting this paper together.
Aaron?
As well as the learning curve, were there tumor factors that you may have been able to predict these complications happening in advance, or patient factors such as adhesions?
Yeah.
And if you could predict those, have you kind of devised any drills or backup plans within your team, so that if you can predict that you may have a case like this, you know how you're going to handle it?
Yeah, we looked at that. We tried to figure out if we could predict anything that could lead you to identify these complications. Most of the worst complications were on little tiny things. As you saw, there was even a pneumonectomy for benign disease. So it's very difficult to predict these. It doesn't correlate with the learning curve. It doesn't correlate with the surgeon's experience. And I think this just stresses the fact that we have to maintain a level of vigilance when doing these operations. You can't let your guard down, ever.
Dominic?
Thank you, Roger. I appreciate your modesty, as usual. Just a question about the case 4, who experienced a thrombosis of the pulmonary artery after the operation. Did you give an anticoagulation therapy during the arterial clamping to this patient in Catastrophic?
When it comes to a primary anastomosis, we don't anticoagulate. In this particular patient, it's interesting that a pneumonectomy had to be performed because you can tie off the main pulmonary artery, and patients can do okay with that, as recently reported in the Journal of Thoracic Surgery in a series of letters to the editor. So we don't use anticoagulation, and that particular patient was not tried on anticoagulation.
Because it joins the question to Dr. Galetta yesterday, who do not give anticoagulation therapy during the arterial clamping. Personally, I think it's necessary to give such anticoagulation therapy.
Microphone two.
Steve Yang in Baltimore. Again, thanks for confessing your sins. You said you didn't have a complete database or ability to check all complications. One of the things I always worry about is taking out the wrong lobe, because when you've got a spot, you're not exactly sure it's sitting in the fissure, you look at the 3D recons, you're still not quite sure. How often do you think that's happened to me once, but I was just curious how often that might.
Well, I appreciate your candor with that. That is something that frightens me to death, and I've opened patients because I couldn't really identify, was it the upper lobe, was it the middle lobe? The first thing that I explained to the residents before starting the dissection, my best instrument is my finger. I put it in there, I make sure I feel where that tumor is, and I won't start the dissection until that happens.
Mm-hmm. And secondly,
and if there's a doubt, I'll open.
You went through a lot of them in detail. I didn't quite understand how do you get bilateral fistula from a right middle lobe, the esophageal fistula.
Yeah, that's an interesting case. That patient underwent a level 7 mediastinal nodal dissection, and I don't know how that happened. The patient was probably the one that is doing the worst out of all the complications, and I don't know how to use that to learn from. Maybe we need to look at the ACOSOG study of dissection versus sampling, but you shouldn't change your operation from thoracotomy when you're doing it VATS. So if you believe in nodal dissection, complete nodal dissection, then you should do the same with VATS.
Last comment, Todd.
Quick question, Todd Demi, Buffalo. Have you thought of using an intubating video bronchoscope that the anesthesiologist could pass to help identify whether or not an airway is being pinched or narrowed? And that's for the airway complications. And have you thought, or these ones where you have trouble seeing what vessel you're taking in the superior hilum, were you using a high definition scope, or were you able to get your scope at enough of a right angle so you're really looking at the lateral hilum so you can see those vessels coming out? Could that have been an issue for those transection issues? Thank you.
I think it depends on which surgeon you ask. All of us over there were using 30-degree scopes. Initially, we were using regular scopes, then we transitioned to high definition, and it didn't appear that that came into play. I think your idea of using a bronchoscope is helpful in cases where there's a question, but the thing to note in this study is that there were a lot of VATS lobectomies performed successfully. I mean, 633 VATS lobectomies performed successfully is not a small number, which is why you have to always keep your eyes open for one of these potential complications, because I think it'll hit you when you least expect it.
Well, thank you very much. It was an exciting presentation. And thanks to the audience for your great participation.